Now, if you look at this particular case, what I have done is I try to reduce. I pass one K wire, and then behind that there is a second K wire. So you can see there are two K wire which has been passed. Over that, we have first Ahmedabad screw. There is a posterior side where we have not put the one side we have put, and then after you can see both sides we have put the Ahmedabad screw. You can see very easily with the same method. Now we know that there is a fracture below. Now for that fracture, what you have done is a classical medial plate which has got an angle. This is a medial plate. This is not a posteromedial plate. Posteromedial is not required because once you put it a good reduction, there is no chance that the posterior tilt will occur. Unless your screws are not holding well with the proximal fragment, it will not go like this. So here you can see that I've just passed the first pin, and when I pass, then the assistant is going to just hold the skin, so I can just pierce the skin. Much in the same way, you can see on the other side where I pass, I'm just tightening inside, and you can see the IITV side, the images where we are able to engage the screw. Now, engagement of the screw is a feel, unless it is engaged well, but after so many cases, I have never ever failed in engaging the screw because the diameter of the guide pin and all these things are so precise that in that metaphyseal open roomy area, it is very easy to engage. There is no bone dust which comes in between. So, good tapping, good calibrated drilling, and a proper size blunt guide pin. All these things makes a big difference in engaging the screw. And thereafter you see, once such a fixation is done, patient is able to do this type of movement on the second day itself. Now this is what it was very much satisfying and amazing for all of us, that this is how it gets the best of the fixation at least intercondylar region. It also can be used with where we have pushed couple of anteroposterior screw to hold this fragment, and there is an interfragmentary Ahmedabad bolt where he is able to do immediate movement. And then after, once the fracture heals, you can go for full movement. Now there is another case. Look at this. There is already an interlocking screw, interlocking nail has been used, IMSing, and thereafter there is a fracture. This is a very bad fracture. Now, I have told you that in such cases, there is no need to put two plates. Put only one medial plate and let this medial cortices be in continuation. So, this medial plate, which we call it a point supported thin plate, we are just putting the fragment above and the fragment below absolutely on that surface. And with that, you can see beautifully it has been fixed. Such a bad fracture, if you see postoperatively, hardly able to see the fracture line, and all things are absolutely anatomical, and he is able to do all this movement. Yes, where there is a medial condyle fracture as well, which we could see only on only on CT scan, but there is a depressed fracture of the which is fixed. Two Ahmedabad bolt has been put, and very small on the medial side a point supporting plate has been put. Now with that he is able to do even with a steel. This how come this is possible? It is because we call it as a minimum implant fixation. And this is a minimum implant fixation once you have able to elevate the depressed fragment very well and place the screws absolutely underneath that, it is very easy to fix such fractures and allow early movement. Similar, a lateral condyle, a big fracture, only two screws, nothing else. They are steady enough. Now here, why we do not want, excuse me. So on this side, you can see that because of the two screws, because of the intact medial condyle whole wall, there is no need to put anything on medial side. Just putting this screw is enough to get the full movement, and that is very important aspect and principle. Here you can see this is how I have put the screws, and during surgery also you can check under IRTV that how much is the stability with the two screws. And you can find it very easily.
Excuse me.
So yes.
The X-rays again, the lateral condyle, the
Hmm.
previous case.
Hmm.
X-rays again. Okay. Here,
Hmm.
where is the male screw and female screw?
Now here, this is what I showed you. Preferably you put the female screw on the lateral side, but there are cases
Hmm.
where you want a sliding part on this side.
Yes, that's what I saw. That's the
Yes.
reason I
So
said.
sliding part we want on that side, that will be more scientific. You can do on this side also, but the sliding part if it is this side, at least the fracture line should be on the sliding part.
Okay. Okay. Thank you.
So now this is another case. Look at the horrible case. Having a depression of the lateral condyle, this lateral condyle which is depressed almost 3 centimeter below. A very unique case where the lateral condyle of the femur has gone so much deep inside the lateral condyle of the tibia, which is so much depressed. Now, and there is a fracture line which goes right up to here. So I have put one intraperoneal screw, one CC screw which is 6.5, one Ahmedabad bolt, and because there is a lateral fracture line, I put anteroposterior one medial interpigmentary screw. You can see very well. Now this is minimum implant fixation concept, which is a new concept where only this much of the things is enough for the tibia, even if it is a weight bearing bone. Usually we do not allow weight bearing so immediately because all these plateau fractures we try to wait for 3 months to 4 months, and depending on the patient's compliance we allow. But let us see how this fragment has been elevated. So this is a huge depression. So we need to have a special instruments like double curve punch. With that punch, we can put this thing inside. Now, if you look very carefully, this is how I have captured of the medial side first. I don't want to lose medial side. There was an anteroposterior screw. Let me just wait.